Thank you. Thank you for inviting me today, and thank you everyone for being here. I'm going to switch gears a little bit and talk about bloodstream infection and talk about some recent evidence guidelines that have been published. These are my conflict of interest. And just talking about rapid diagnostics from positive blood cultures, this is common practice in many hospitals in many countries. Now, they might look different. We all use different rapid diagnostic tests, but this is more common in bloodstream infections. And really, we're looking for organism identification, and some of them have corresponding antimicrobial resistant mechanisms, so not susceptibility results, but we can use these to optimize patient care. And so some of the rapid diagnostic tests that we're talking about can be nucleic acid amplification tests, hybridization assays, the use of mass spec for bacterial identification, and some rapid biochemical identification. And so you're probably all aware of this, but this was the first randomized clinical trial used to look at rapid diagnostic testing within blood cultures. And here there was 3 arms. They had a control arm, a nucleic acid test-only arm, and then the test with antimicrobial stewardship or communication arm. And so what you can see here is with the control arm, it takes up to 48 hours for susceptibilities actually in all of these arms, right? So we're looking at the rapid diagnostic bacterial identification. And you can see the de-escalation takes about 36 hours when using the control arm. When you use the PCR alone, it decreases just a little bit to 36 hours. But if you actually utilize the test and also have a type of communication or antimicrobial stewardship, you can decrease that even further to 20 hours. So this was one of the key papers out there in the literature really showing that rapid diagnostic testing in blood cultures is important, but that it also needs this aspect of communication with it. Also, other papers showing that antimicrobial stewardship matters, looking at the tests with and without antimicrobial stewardship. So here's a paper, and the data really showed that it favors using rapid diagnostic tests, but only when used in conjunction with antimicrobial stewardship. And so we're just sort of building up the evidence on using rapid diagnostic tests. So we need not only the test, we need communications, but then we're looking at patient outcomes. And so there's studies to show that it can improve patient outcomes by using rapid diagnostic tests and communication. So in this paper, you can see pre-rapid diagnostic test is in gray, post-rapid diagnostic test is in red, and I think it might have been cut off a little bit, but the first set is just switch in antibiotic, and you can see that when you use a rapid diagnostic test, that you get a switch in 28 hours versus 44 hours without the test. And then it looks at escalation and de-escalation of antibiotics. And again, with both of those, you can see that there's a difference without the rapid diagnostic test and then post using the rapid diagnostic test. But what I want to talk to you today about is the American Society of Microbiology's evidence-based laboratory medicine practice guidelines around the diagnosis of bloodstream infections. And really, these guidelines focused around length of stay, mortality, and time to targeted therapy. And so there was an expert panel, and they used PICO to formulate a question, review the literature, and then provide recommendations for the use of these rapid tests in BSI and how it affects patient outcomes. 4 databases were used, and then we used the grade approach for rating the certainty of evidence and the strengths of recommendations. And we looked at papers from January 2011 to April of 2019. What we found with most of the papers that there were different intervention chain types. So there was comprehensive, and so the comprehensive chain types, they include both pre-analytical procedures, the organism identification, which is the rapid diagnostic test, and communication methods. There were also papers that only focused on the test. So how did the improvements of just the intervention of the test for organism identification, but not communication around the results of the test. And then there are also communication chains where the primary intervention was just looking at communicating those results to clinicians or pharmacists or the antimicrobial stewardship teams. And so there's a lot of literature out there on bloodstream infections and rapid diagnostic tests. So before we actually started all this, we ended up doing a scoping review to really map the evidence of rapid diagnostic tests. And when we mapped this evidence, what it really showed is that the data is strong around 3 specific clinical outcomes, which I had already mentioned, which is your time to targeted therapy, your length of stay of the hospital, and mortality. And so there are different chain links between the test prep, the test link, and the communication link throughout these papers that looked at these 3 clinical outcomes. And so here's what we looked at, all the papers that we looked at, which papers we excluded, and came down to it. We had 51 articles that fit looking at length of stay, mortality, and time to targeted therapy during that time. And so we came up with 8 recommendations. We had 1 recommendation for decreased time to targeted therapy. So the panel recommended that, that clinical laboratories implement rapid diagnostics and that it be in combination with a comprehensive plan to actively communicate these actionable results. And so if you look at all of the intervention chains, so communication, comprehensive, or test, altogether those showed that there was about an 18-hour decrease into time to appropriate therapy. If you looked at comprehensive intervention, so the test with communication, you got about a 25-hour decrease in time to appropriate therapy. Then we looked at recommendations for length of stay, so studies looking at length of stay. We looked at hospital length of stay in the ICU, and infection-related length of stay, and came up with recommendations that the panel recommended using rapid diagnostic tests with a comprehensive communication plan for these 3 different types of length of stay to decrease length of stay. And so what we saw was a reduction in length of stay for 2 out of the 3, with the exception was infection-related length of stay when using comprehensive intervention chains. Again, the test with communication. So you can kind of see a theme here that most of the literature really shows that you have to have some type of communication. And then we looked at mortality. So could we use rapid diagnostic tests and see a decrease in mortality? So we looked at papers, there are many papers looking at this, but their definitions of mortality were all a little bit different. So we had to take the definitions from the paper and kind of break them down. And so we made 4 recommendations. 1 was decrease in the 30-day mortality. Then we looked at non-specific mortality in patients, in-hospital mortality, and then the 4th one was infection-related mortality. And so we recommended the use of rapid diagnostic tests, again, with a comprehensive plan for communication and looking at all the 4 types of mortality. Really what we saw the most in the literature that was significant was 30-day mortality. And so we saw a 27% lower mortality associated with these process improvement efforts around rapid diagnostic testing with bloodstream infections. We saw a 36% decrease if you use the comprehensive intervention types. And then if you use just the test alone, that did not achieve any statistical improvement when it came to mortality when using these tests. And then the hospital mortality was decreased by 10%. But what you see with decreased time to appropriate therapy, length of stay, mortality actually had a less of an impact when looking at the literature when using rapid diagnostic tests and active communication. So there were limitations. What we found in the literature is a lot of the papers, it was really hard to, understand what their definitions were, how the might be blinded, et cetera. And so that's why only 51 papers were included. So some of the limitations that we weren't able to analyze the difference between the different types of rapid diagnostic tests. So I mentioned at the beginning, it could be a molecular test, hybridization, MALDI-TOF identification, or a rapid biochemical. We didn't have enough papers to actually break that down. So what we found is, just the use of having those results quicker. It might not matter what that method is, that it would decrease the time to appropriate therapy and the other outcomes. We weren't able to stratify it by gram-positive and gram-negative. So between the 51 papers, some of them were specific just for Staph aureus. Some were more broad range for both gram-positives and gram-negatives. And so we didn't have enough data to actually break that down to say if there was a difference between patient outcomes, if it was a gram-negative or a gram-positive. All the different hospitals, a lot of them didn't talk about their algorithms of treatment using rapid diagnostics. So many of the hospitals, they define their empiric therapy and their formulary different. So we weren't able to look at a standardized escalation or de-escalation algorithm within the studies. There were only a few pediatrics, so we weren't able to break it down between adults and pediatrics. And really what we saw was that there was a limited number of high-quality outcome-based studies to inform these systematic reviews. So a plea, I've already heard pleas from my colleagues here, we'll plea for this too, for sort of better research around looking at clinical outcomes. So in summary, the quality of the evidence in some of the cases were low to moderate due to the type of studies, the controlled studies. There's not many randomized clinical trials. We did recommend the use with active communication, but many papers didn't actually define what that active communication is. So it can be phone calls, traditional pages. We use HIPAA-compliant text messaging at my hospital, so you can use that too. It also didn't always break it down on who got the message. Did it go to the antimicrobial stewardship team first, and then they reached out to the provider? Did the lab call the provider? Although we recommend communication, there's no descriptive communication that needs to happen. There was not enough evidence to impact the different RDTs separately, which I mentioned before, or different patient populations. And then some of these studies, these results might not be generalizable to all of the hospitals. So the evidence gap that we have in bloodstream infection, rapid diagnostic RDTs is that we have limited data on real-world guideline adherence and implementation. There's a need for high-quality RDT-specific prospective studies, and there's insufficient evidence in looking at RDTs in things like community settings or resource-limited environments, or even in specific patient populations. We weren't able to break that down. And then it's unclear the cost effectiveness of using RDTs across diverse health systems. And so the future directions of looking at bloodstream infections, rapid diagnostic testing, things that I think about are we using it effectively? Are people using the guidelines? Are we using it effectively? Are there standardized clinical pathways and response protocols that we should be using for some of these rapid diagnostic tests? How are we monitoring the process of the metrics of these tests? So yeah, we did a study to begin with, but are we still monitoring these to see the impact? What are the guideline adherences? And then what are the barriers to implementation? So is it administrative? Is it workflow, staffing, reporting? Is it understanding of the clinicians of what the results are and what they mean? And really what I think we need is pragmatic trials assessing the implementation strategies of rapid diagnostic testing and studies isolating the independent impact of RDTs. So, thank you.